Good afternoon. Today, I'd like to talk to you about our experience with the inclusion of internally displaced persons in the mental health training for a grant we got 4 years ago to address the mental health needs of internally displaced persons in Colombia. So this was with forcibly displaced women uh, in Bogota, in and around Bogota. The project was called OSITA. It was funded by Grand Challenges Canada. This audience knows, of course, very well the staggering number of internally displaced persons around the world. Unfortunately, Colombia has this record of 15 consecutive years ranked either first or second, the other country being, of course, Syria, globally in the number of IDPs. As you know, the source of this displacement is this brutal and protracted armed conflict, like 60 plus years now, which in 2016 was transitioned to post-conflict status, but it's quite unstable. Uh, so this insurgency pitted left-wing guerrilla and right-wing militia against Colombian forces and national police. And the pattern of the flight was a little atypical from rural to urban centers in this case. So the outreach screening and intervention for trauma in internally displaced women in Bogota was a pilot step care model involving this evidence-based psychotherapy, interpersonal counseling that our team had handed over to the World Health Organization for global dissemination. And we used it for depressed and traumatized IDP women. It was a consortium of researchers from Columbia University, University of Miami, and Universidad de los Andes. Our clients and our IDP mental health providers were exposed to staggering and unspeakable, brutality and trauma. 3/4 of them have witnessed murder, assassination, many times, of family members. They witnessed massacres, violence against women, rape, severe injuries, etc. And it didn't stop when they were resettled in Bogota. It continued in the form of more, chronic stressors and adversities like unemployment, poverty, lack of meeting basic needs, physical violence, etc. So it was a step care model, and the constant part was the provision of interpersonal counseling. It was a model where the patients were getting as much or as little mental health, assistance as they needed. Now, I don't want to spend too much time on the project. It was successful in indicators of depression. We saw, a significant difference before and after. Same thing for post-traumatic stress disorder in the PCL. Now, what I want to focus on was the capacity building of interpersonal counseling. So our mental health therapeutic teams included psychiatrists, psychologists, but also IDP, community mental health workers, promotoras, who had high school education. They didn't have mental health, or higher education. What was the purpose of including them in the team? Well, first of all, to sensitize and educate us, the mental health professionals that were involved in the training, because they had the lived experience, to guide us on the needed cultural and contextual adaptations of this model, to guide us on the delivery methods of interpersonal counseling that included very important partnerships with IDP communities to promote access. And they had unique access to these communities, and also increase the workforce. the available workforce that was severely burdened in Colombia with the mental health needs of IDPs. Through this strategy we have in mental health, well, in global health, I should say, called task sharing, which is appropriately delegating tasks that are typically performed by specialists to non-specialists, of course, with appropriate oversight. This is our team, and the women on my right were IDP women. Now, the training had, and the subsequent implementation of the treatment had very rigorous indicators and benchmarks of competency, right, of knowledge and skills. So these were two mother and daughter IDP team that were the stars of our training, and they met these competencies, they achieved excellence in meeting these criteria. They were also very humble, going back, studying, asking questions. They also had not only, they were excellent, but they had some added advantages, I have to say. They have high levels of access, knowledge, and credibility in those communities. And they brought the C part of the community health worker, right? The linkages to the community. So when our clients were feeling better and were able to function better, Elvia and Areli, these two women that you saw, were able to link them to community resources and help them also break the social isolation in ways that the more elite clinicians couldn't do. Also, they're more immune to brain drain, which is a huge problem for capacity building, because we prepare, a team, a very well-trained team of nationals to, take over while we phase out, and then international NGOs, and national NGOs, hire them away. Community health workers are more immune to brain drain. Now, the challenges were the management of the dynamics of the inclusion in the training team, and this, the mental health professionals at times felt threatened. And they were, they felt that perhaps they may be easily substituted with people with high school, training. So it was very important to, reassure them and to show them that it was a task shifting. So their task would be to train, supervise, oversee, and also treat complex cases that community health workers could not do. Sustainability was and still remains a big challenge, though we did not resolve. Because there are no formal structures in between professional mental health providers and promotoras. So there are in no man or no women's land there. And that involves usually coordinations with ministries of health, education, and labor. So I'm finishing with our recommendations for sustainability, which is that we cannot have, we need a continuing education model and opportunities for advancement of the lay internally displaced persons, and a place for them in the system, which means, work with governments, which we have done in other areas, like in Lebanon. Now we are attempting to provide this model in Tanzania with Burundian Congolese refugees, and Peru with Venezuelan refugees, and in partnership with UNHCR. Thank you very much.